Labor and delivery. When should women with antepartum hemorrhage be delivered, and what mode of delivery should be employed in women whose pregnancies have been complicated by antepartum hemorrhage? If fetal death is diagnosed, vaginal birth is a recommended mode of delivery for most women, provided the maternal condition is satisfactory, but cesarean birth will need to be considered for some. This is addressed in Green Tab Guideline number 55. If the fetus is compromised, a cesarean section is the appropriate method of delivery with concurrent resuscitation of the mother. Women with antepartum hemorrhage and associated maternal and/or fetal compromise are required to be delivered immediately. The optimum timing of delivery of women presenting with unexplained antepartum hemorrhage and no associated maternal and/or fetal compromise is not established. A senior obstetrician should be involved in determining the timing and mode of birth of these women. What intrapartum fetal monitoring should be employed for women whose pregnancies were complicated by antepartum hemorrhage? Women in labor with active vaginal bleeding require continuous electronic fetal monitoring. In women who are in preterm labor, whose pregnancies have been complicated by major antepartum hemorrhage or recurrent minor antepartum hemorrhage, or if there has been any clinical suspicion of an abruption, then continuous electronic fetal monitoring should be recommended. In women who have experienced one episode of minor APH, in which there have been no subsequent concerns regarding maternal or fetal well-being, intermittent auscultation is appropriate. Women with minor APH with evidence of placental insufficiency, such as fetal growth restriction or oligohydramnios, should be recommended to undergo continuous electronic fetal monitoring. What is the optimal mode of anesthesia for women who have experienced antepartum hemorrhage? Regional anesthetic is recommended for operative delivery unless there is a specific contraindication. In case of APH where maternal or fetal condition is compromised and cesarean section required, a general anesthetic should be considered to facilitate control of maternal resuscitation and to expedite delivery. A consultant anesthetist should be involved in the intrapartum care of women with antepartum hemorrhage with associated compromise. What is the appropriate management of the third stage of labor in women with antepartum hemorrhage? Postpartum hemorrhage or PPH should be anticipated in women who have experienced antepartum hemorrhage. Women with APH resulting from a placental abruption or placenta previa should be strongly recommended to receive active management of the third stage of labor. Consideration should be given to the use of ergometrine oxytocin to manage the third stage of labor in women with APH resulting from placental abruption or placenta previa in the absence of hypertension. Should women presenting with antepartum hemorrhage who are RHD negative be given anti-D immunoglobulin? Anti-D immunoglobulin should be given to all non-sensitized RHD negative women after any presentation with APH, independent of whether routine antenatal prophylactic anti-D has been administered. In the non-sensitized RHD negative women, in the event of recurrent vaginal bleeding after 20 plus 0 weeks of gestation, anti-D immunoglobulin should be given at a minimum of 6 weekly intervals. In the non-sensitized RHD negative women, for all events after 20 plus 0 weeks of gestation, at least 500 international units of anti-D immunoglobulin should be given, followed by a test to identify fetal-maternal hemorrhage greater than 4 milliliters of red blood cells. Additional anti-D immunoglobulin should be given as required. How should massive antepartum hemorrhage be managed, and who should be included in the resuscitation team? The management of massive APH should follow locally devised multidisciplinary protocols for massive obstetric hemorrhage. The management team should include a consultant obstetrician, anesthetist, hematologist, and midwifery labor ward coordinator. Laboratory staff and portering staff should be alerted. How should the woman presenting with an APH who develops a coagulopathy be managed? In women who have experienced a massive blood loss or a major abruption, the development of a disseminated intravascular coagulation or DIC should be considered. Clotting studies and a platelet count should be urgently requested and advice from a hematologist sought. Up to 4 units of fresh frozen plasma and 10 units of cryoprecipitate may be given whilst awaiting the results of the coagulation studies. How should the woman presenting with an antepartum hemorrhage who is taking anticoagulant therapy be managed? Women receiving antenatal anticoagulant therapy, usually low molecular weight heparin or warfarin, should be advised that if they have any vaginal bleeding, they should not take any more doses of anticoagulant medication. They should attend hospital urgently, be assessed on admission, and further doses should only be administered after consultation with medical staff. In women whose pregnancy is complicated by antepartum hemorrhage, how should the neonate be managed and by whom? Major or massive APH may result in fetal anemia and fetal compromise. The neonate should be assessed by a senior pediatrician or a neonatologist. In minor APH, clinical judgment should be used. With continuing hemorrhage, it would be appropriate to request pediatric support at the time of delivery. How should the woman with an extremely preterm pregnancy, 24 plus 0 to 26 plus 0 weeks of gestation, and antepartum hemorrhage be managed? Regardless of the gestation, the mother's life should take priority. She should be resuscitated and stabilized before any decision is made regarding delivery of the baby. A senior pediatrician or a neonatologist should be involved in the counseling of women when extreme preterm birth is likely. Conservative management is usually appropriate when APH occurs in the extremely preterm pregnancy, less than 26 plus 0 weeks of gestation, and the mother's condition is stable. When the bleeding is considered life-threatening for the woman, or there is evidence of cardiovascular compromise that fails to respond to resuscitation, consideration should be given to delivery of the fetus. At these gestations, experienced neonatologists should be involved in the counseling of the woman and her partner. The use of practical, clinical guidelines in these situations aids consistency and promotes informed, supportive, and responsible choices. The British Association of Perinatal Medicine have produced a framework for the management of babies born extremely preterm or less than 26 plus 0 weeks of gestation. What are the postnatal issues that need to be addressed in women whose pregnancies are complicated by antepartum hemorrhage? The postnatal management of pregnancies complicated by major or massive APH should include thromboprophylaxis, debriefing, and clinical incident reporting. What is the role of obstetric skill drills to improve the management of antepartum hemorrhage? Management of a major APH should be included in obstetric skill drills. Principles of management of massive antepartum hemorrhage, blood loss greater than 1,000 milliliters, and/or signs of clinical shock. Personnel required are the following: call experienced midwife in addition to midwife in charge. Call obstetric middle grade and alert consultant. Call anesthetic middle grade and alert consultant. Alert consultant clinical hematologist on call. Alert blood transfusion laboratory. Call porters for delivery of specimens and/or blood. Designate one member of the team to record events, fluids, drugs, and vital signs. Full protocol for massive hemorrhage, blood loss greater than 1,000 milliliters or clinical shock. Assess airway. Assess breathing. Evaluate circulation. Oxygen by mask at 10 to 15 liters per minute. Intravenous access. 14-gauge cannula multiply by 2. Position left lateral tilt. Keep the woman warm using appropriate available measures. Transfuse blood as soon as possible. Until blood is available, infuse up to 3.5 liters of warmed crystalloid Hartmann solution, 2 liters, and or colloid, 1 to 2 liters as rapidly as required. The best equipment available should be used to achieve a rapid warmed infusion of fluids, and special blood filters should not be used as they slow infusions. Fluid therapy and blood product transfusion. Crystalloid. Up to 2 liters Hartmann's solution. Colloid. Up to 1 to 2 liters colloid until blood arrives. Blood cross-match. If cross-match blood unavailable and the clinical situation is urgent, give and cross-match group-specific blood or give ORHD negative blood. Consider the use of red cell salvage if available. Fresh frozen plasma. 4 units of fresh frozen plasma, 12 to 15 milliliters per kilogram or total 1 liter, for every 6 units of red cells, or if prothrombin time and or activated partial thromboplastin time are greater than 1.5 multiplied by mean control. Platelets concentrates. If platelet count is less than 50, multiply by 10 to the 9th power per liter. Cryoprecipitate. If fibrinogen is less than 1 gram per liter. With continuing massive hemorrhage and whilst awaiting coagulation studies, up to 4 units of fresh frozen plasma and 10 units of cryoprecipitate, equivalent to 2 packs, may be given empirically. Apply clinical judgment in each situation. The main therapeutic goal of the management of massive blood loss, as outlined in Green Top Guideline number 52, summarizes the main therapeutic goal of management of massive blood loss is to maintain the following: hemoglobin greater than 8 grams per deciliter, platelet count greater than 75 multiplied by 10 to the 9th power per liter, prothrombin time less than 1.5 multiplied by mean control, activated partial thromboplastin time less than 1.5 multiplied by mean control, and fibrinogen greater than 1 gram per liter.